friends, welcome to session 10. And this is the last session of the program, but not the end of the program because we are going to continue our interaction and working together. Topic of discussion today is very important, very relevant, and therefore I kept it for the last because that's something that we are not very comfortable handling, but then we have to prepare for all sorts of communication. The topic of discussion is disclosure of medical error. Uh, Although we don't want errors to happen, but we know errors do happen. And then when it happens, again, most of the times the attempt is to cover it up and not to disclose. But then there are situations it's practically impossible to sometimes cover it up. You have to talk to the family. So the discussion is going to be all about how do we go about doing it? How do we go about disclosing the medical error? Although disclosure of medical error is the responsibility of the physician or the treating doctor, but I think the uh, team as such also plays a very big role in managing the situation. One, because a lot of time uh, staff sometimes goes and shares the information unknowingly with the family and with relatives of the patient, and that also creates a lot of conflict. I'm sure you must have seen this happening in some of the situation. So staff has to be sensitized to the fact that it's not appropriate to go and share information with the family and the attendant without the permission of the treating doctor. A lot of time, if an error has happened and if our behavior with the patient party is not cordial or not respectful, or we are still acting aggressive or rude with them, so it's something like it adds insult to the injury. And when they get to know about the error, they kind of not only take revenge, but they're very unhappy that, I mean, you make mistakes and still you kind of show as though you have done your best to the patient. So staff has to be even sensitized to the point that the errors happen. One, we can't go and talk about the error to the patient party without the doctor's permission. And also our behavior should be cordial, calm, and composed, especially when this whole event is going on. And we have to act very responsible. So right from the security guard to the general duty assistants and nurses and other support staff, they have to be sensitized to the importance of professional behavior, especially in such situation. So starting with this background, my question to all of you will be, I know I have a habit of asking a question to start with. That's probably to bring all of us to the relevance of the topic. So suppose if you were in a flight which kind of had a near miss kind of a crash. Pardon me for taking this example, and I know recently we have had such an unfortunate incident of the crashing the flight. I think that has left all of us sleepless for a number of days. But this is one example I often talk about. Suppose if there was some turbulence or something, there you really got scared, and people also got scared in the situation. And some of the people who were not wearing the belt, they also, kind of got hurt in that, turbulence. So once you land safely, fortunately, nothing happened, or you were not like any seriously injured, or even other passengers were kind of fine. What would you expect, and from whom would you expect? If anybody would like to answer, what would you expect, by the way, in such a situation?
So I think, ma'am, what is expected is, a frank, telling what has happened,
Hmm.
why it happened, and by the most,
Hmm.
skilled person in that place, maybe the captain in this case, to
Absolutely.
explain this has happened and extremely sorry for it, and something like that has to be done.
Absolutely. I think you have pointed all three, four major points. One is we would like to know everything, what exactly happened, and a very frank and honest explanation. And why did that happen? And we would want that explanation coming from somebody who knows the system, who is aware of how things function and what went wrong. And I mean, you would like to know about it. So similarly, lot of time, when errors happen in patient care, they can sense it. They can see either the patient deteriorating or some changes happening in the patient's condition, or a patient not improving, or even from our behavior and body language, they can make out that there's probably something that's going on with the patient. And the family and the attendants expect us to come and explain to them or tell them as early as possible. But we all know how disturbed we are at that moment, how perturbed we are. We are occupied with settling the patient, and on the other hand, the family expect us to explain. And if we are not prepared how to go about admitting, that's where the real tussle starts. They want us to explain, and somewhere it comes out as though we are covering up. We may not be covering up, but it comes out as though we are covering up. And then that's where the real tussle starts between us and the patient party. So I can see some answers coming in the chat box. Dr. Purnima says transparency and support. Absolutely, I think frank and open and honest explanation of the situation. So even if they try to cover up, I mean, somewhere we can sense that they are not coming out very honestly. And then assumption of responsibility. That means who takes the responsibility? I mean, are they taking the responsibility of something that has happened, and are they truly coming forward and taking the responsibility, or again are they covering up? So that means everybody expects some explanation and some answer from us when we are handling the patient. So let me take you through some cases that they're all again real life cases, and imagine what the family or the patient would expect from us and what exactly happens in that situation. Give me 1 second to, yeah. So I hope you are able to see see my screen, see my slides. Okay, thank you. Yeah. So this is a recent case that happened with Indigo. It was flight probably to Jammu or Srinagar, and because of hailstorm, the front portion of the aircraft got damaged, and it led to a lot of turbulence, and the flight actually going up and down, and the passengers inside were very scared. But thankfully, nothing serious happened, and they landed, safely. And I'm sure they must have expected somebody to explain them what exactly happened. So these are some of the cases that I want to share with you, and they're all real life cases, and they have been seen, and these cases are available even on, if you will Google search, you will be able to find details of these cases. So this is a case of a patient who was admitted to a state-run trauma center in Delhi. He had head injury after a car accident, but unfortunately, he was mistaken for another patient who had a broken leg, and he underwent the surgery for a repair of fracture, which he actually did not have. So this is one case which was in limelight, and there were a lot of hue and cry about it. This is another case again from one of the very premier hospitals of Delhi. So two doctors were accused of failing to diagnose timely, a condition where the patient had high blood pressure with ECG changes. She was a physiotherapist actually, and because she was not diagnosed on time, that led to delay in treatment and unfortunately death of the physiotherapist. And she went into cardiac arrest and she died. So again, this case was in news for quite some time. Another case where the patient actually had gone for some minor complaint of abdominal pain, and the doctor mistook the patient for another patient, and they made an arteriovenous shunt for dialysis in this case. This is a recent case shared by one of the participants from the program. So I'm sure you must have seen this in Kota. It happened. The man had come with his son for the surgery of his son, and when uh, his name was called, unfortunately, there was another patient who had the same name. When his name was called, he rose and he got up and he went, and he was mistaken for a patient, and he underwent the procedure. And unfortunately, this person had facial palsy, so and he could not speak properly, and I mean, probably was not even clarified and asked about his identity. And this is a recent case that happened in Kota. So these are few examples, I think, that bring to our understanding that this lot of errors happen around us, and we can't disagree to it. We know lot of wrong side surgeries, wrong medication, wrong organ removal, wrong treatment, wrong patient. These are very, very common, and we see them happening, around us. And if I go by the report by Joint Commission, medical errors are the third commonest cause of death. Like 250,000 patient dies every year in US because of the medical errors. We haven't done any study in our country. I don't know if we did, where we will stand, because I'm sure it must be much more than that, because the population here is almost like 5-6 times more than the population of America. So you can well imagine how many errors we must be doing and how many patients must be dying because of that. But the focus of the discussion today is not about how do you prevent errors. The focus is on how do you go about disclosing the error. So we are going to stick to the agenda. And now my question is, how do you go about disclosing medical error? So I'm going to stop sharing the presentation, and I want to know from all of you, how do you usually, I mean, in case if you have seen something like this, how do you disclose the error? Have you seen anybody disclosing the error? Have you ever uh, had the chance of doing it? If somebody can share their experience, that would be really nice. Anybody? It could be error, in a nursing procedure or in a medical intervention. Yeah, Dr. Manjusha, thank you so much for coming up. Please go ahead. Yeah.
Good evening, ma'am. In fact, I've had the opportunity to disclose when I was doing my senior residency. We had a child who had been admitted in the ICU, and for some reason he was on steroids. And by mistake, my resident, instead of milligram, she mentioned it as gram, in grams instead of milligrams. So, unfortunately, a very high dose of methylprednisolone grams was administered by again a newly appointed nurse. And we noticed this when the child started developing headache and features of raised ICT almost 2 months back. That is when we went back, we found that the orders were wrong. So we called in the parents. We have a counseling room. So myself, my chief, the resident involved, the nursing staff, all of us sat together. We called in the parents and we told them that whatever symptom the child has at this point of time is due to a wrong dose of the medication that we gave. And we apologized for the same, and we convinced them that the child was otherwise stable at that point of time. And we have withdrawn the medication and she'll be under our care. Because it was a government institute, all the treatment was free. So we didn't have to actually take care of that part. Fortunately for us, the parents just listened to whatever we said and they said, yes, please take care of my child. So and we were also surprised because we expected them, to get angry, which they didn't. And probably they were too stressed and tensed because of the child's condition to even tell us. And there is this notion that when you're admitted in the PIC of a government medical college, your child is really sick. So there is no bargaining beyond that. Probably it would have been the experience if it was a private hospital.
So I really congratulate you for coming out honestly and explaining to the family. Usually, I mean, a lot of time we have seen whenever some wrong medicine or wrong dose is given, nobody comes out and admits because they know it can't be proved and it can't be seen. So nobody can exactly find out what went wrong and what mistake we did. But I'm glad that you came out with it, and you are lucky that the family kind of, accepted your explanation and they did not react to it. But I would say probably your honesty and transparency also played a very big role in kind of making them understand that at least you are honest enough to come and admit. You could have covered it up, you could have avoided the disclosure. But I think it worked for you because you were honest and transparent in that case. But we have seen a lot of time when you explain and tell them, they can react in any way, and we know that happens. Anybody else who would like to share their experience? Can I request everybody to have their cameras on? I mean, this is not what I expect in the last session with you. have your camera off. I know you may be listening. I know you are, listening, but at the same time, you can have your tea, coffee, food. There is no problem, but keep your camera on so that I can see all of you. I need energy from all of you today. Yeah, yeah. Anybody else who would like to share their experience, or if you have seen something like this happening in your uh, situation or in your hospital? Dr. Malik, I'm sure there must be some cases in your hospital that you must have witnessed or you must have handled. Would you like to share any? Or anybody, if not Dr. Malik. Dr. Matthews, would you like to share something from your hospital or your experience?
Well, I don't recollect any particular incident.
Hmm.
I will just say that's a very difficult thing to do.
It's very difficult.
And it's a stressful time for everybody. And
Absolutely.
error is something which is, permanent damage or something which,
Yeah.
like in anesthesia, if it is I remember a case where a patient had, it was a contaminated drug ultimately and leading to paralysis
Hmm.
long
Hmm.
back. But these situations, I remember that it was not admitted to the patient.
Hmm.
It was not admitted, but we knew that the cause.
Hmm.
Though they did react and tried to file cases and all, but it was never proven. But to be
Hmm.
truthful, at that time, it was not admitted as a fault or it was
Hmm.
just as a complication. Whereas the truth would have been that no, it's not to be.
Hmm.
What happens? Such an accident cannot happen. So
Absolutely.
yeah.
That's very true, actually. Most of the times, people, the focus is on covering up because we know the kind of repercussions that can happen and the consequences that can bring forth. So we normally want to avoid all that. Dr. Purnima, do you have any incident to share from your experience?
I don't recollect anything like that, and which I can specifically say. But here I must say that as pediatricians and the fellow pediatricians in the group will understand that whenever there is a case of birth asphyxia, which is a medical condition which can occur.
Hmm.
But when we explain that, there is lot of difficulty because, why did it happen? How did it happen? What were the events that led up to it? So that's one of the most difficult things to explain to a group of people who are waiting for a joyous announcement, and we, tell them that the neonate requires stabilization slash transfer to the NICU or further treatment. So that's somewhat similar. And then why did this happen is the question at the
Hmm.
root. So yes, those are the only experiences which come immediately to mind, ma'am. Thank you.
I completely agree with you. Actually, obstetrics is a very unpredictable branch. So everything goes normal during antenatal, and there's no sign of any kind of fetal distress or any abnormality. But suddenly during labor, something can go wrong at any point of time. And if we have not prepared the family, because we don't like to talk about anything that can go wrong, during labor. So usually the parents and the families also kind of in a, like you said, they are in joyous mood and they are waiting for a good news. And if we talk about something like this, I mean, it becomes very, very difficult to explain them that why it has happened. Although this could be actually something like not an error at our part on our part, but it could just be a complication, something like this. But then there, I remember one case where one of my relative, a young girl, she unfortunately had amniotic fluid embolism, and again, like you said, that I mean, there was no explanation. The patient was moved to a tertiary care hospital with the explanation that there is something wrong and we need to attend to the patient. Although I personally feel the patient had actually passed right there itself. I mean, she wasn't alive and she was moved. But just to diffuse the situation, the patient was moved to the bigger hospital and put in ICU for a day or two. And same way, the family was very, very, anxious and unhappy and dissatisfied. And this is what they were questioning, what has happened and why that has happened. So I completely agree. One is if we have not prepared them for anything, and then when it comes to explanation, we don't know how to go about explaining even the possible complications there that are documented complications. Then it becomes very difficult to handle. So will you be open to doing a role play? Will the group be open to doing a role play? Because that's where we learn. But this time I want some new people to come in so that we we get to see their talent in either being a patient or being a doctor. So I'm showing you the situation, and then I would want you to volunteer to be the doctor on duty who is actually going to explain, and somebody who wants to be the patient's family. So you can read this situation, and then we can decide who would like to. Okay, if you have read the case, anybody who would like to volunteer to be the doctor doing this discussion? You could even actually be, maybe not even if you are not a doctor, maybe you're also kind of a manager. Even that would be okay. If you think you handle such situation, or you have to sometimes handle such situation, I mean, it's okay even if the person, preferably it should be physician, because I know this kind of discussion is always done by the doctor. But otherwise, if anybody wants to take this challenge and wants to try their hands, I'm okay with that also. So otherwise, I'll have to nominate in case if people are not ready to, come forward. So Dr. Matthews, can I request you to be the doctor and do the discussion with the family?
Yes, yes, surely.
Okay, wonderful. So anybody who would be willing to be the patient's family? Shubhra, can I ask you to be the patient's family? Okay. And I want one more person who has not played any role play, who has not done any role play. So that will be nice. Mr. Kumar, so you haven't played any, you have not participated in any role play. Am I right?
Yeah, ma'am.
Okay. So have you read the case? Can I close the case? Can I stop sharing?
Okay, ma'am.
Okay. So I'm going to give me 1 second. Okay. So let Dr. Matthews be the doctor on duty who's going to talk to the family, and Mr. Kumar and Shubhra. So you are brother and sister of the patient. Is that okay? The patient is your brother, and both of your brother and sister to the patient. And now Dr. Matthew is going to call both of you and explain the situation to all of you. So we will switch off the videos. But Dr. Matthews, we are not testing your ability to do it, but we want to learn from the role play, because that's how we learn from the situation. That's the idea. So everybody try to find and observe what he does well, so that we can give him that feedback that yes, you did very well in this, and then what could have been done differently. So 3 to 5 minutes are okay, Dr. Matthews?
Yeah, more than.
Okay. So all of us can switch off our videos. And if I come in, that means that there is something I wish to say, so you'll have to. Okay. So all of you, please switch off your video. Okay, now 3 of you are there. So you can start the session. So Dr. Matthews, how do you want? You want them to come to you, or you want to go out and tell them?
Yeah, I think,
outside the OT.
yeah, I think I will call them
Yeah.
to the one counseling room.
Mm.
So Kumar,
Yeah, doctor.
are you are you related to this patient, Ramesh Tyagi?
Yeah, he's my brother only.
Brother only. So are you along with somebody else, or are you alone here?
My sister Shubhra is there here. She's
So
with
can
me.
I just wanted to discuss about your brother who had
Okay.
come to the
I'll call my
accident.
sister. Shubhra, doctor is calling to discuss.
Yes, I am here,
Yeah.
Dr. Matthews.
Shubhra, your sister?
Yes.
Okay, may I request both of you to just come? He had come to the accident emergency.
Yeah,
with
is he okay?
trauma. He's all right. I can assure you he's all
Okay.
right. So he had come for he with a polytrauma after a road traffic accident. So I
Yes.
request you to just come. I wanted to explain to you what has happened and how is he. So if you could come and sit here in this counseling room. Are you comfortable to sit?
Yes.
And
Yes. Yes. We are comfortable. We just want to
yes.
know what is happening. Yes.
So he, I can assure you, he's doing well. He had come to us with a road traffic accident, and he was not good at that time when he came. So we took good care of him. He
But he
was,
was only laceration type, na, sir. Is
yeah,
there
he was only
anything?
laceration, but he was having multiple, injuries throughout. So we took good care of him, and but little bit unfortunately, we had to do a procedure which was actually not required.
No, no, no. They
But
didn't tell anything here, doctors, that there is no need of surgeries like that, sir. Then
It
how he
was
got
not
an emergency
required. So that's
surgery?
why I'm telling you, we initially managed him well.
शुभ्रा क्या यार क्या
However,
बोल रहे हैं
हाँ
डॉक्टर?
सर, हमसे कंसेंट नहीं लिया गया सर्जरी से पहले.
कुछ भी
Did you
इंसिडेंट नहीं
operate
लिया,
on him
कुछ
without
भी
our consent?
रिगार्डिंग एनास्थीसिया कुछ भी नहीं बोला सर.
okay, so he had given, consent at that time, and there was a little bit of mistake which has happened from our side. We are sorry about it, but I want to assure you he's all right
How
now.
is he, doctor? How is he now?
He's all right. He's absolutely fine. It is.
Okay.
I
So
just
what
want
was
to
the
tell you.
procedure that was done?
So what has happened is a small fracture. It was thought that he had a small fracture on his, long bone or what tibia, what we call.
But we were not told about any fractures. We
We
were
didn't
only
aware
told
that,
about
sir.
the laceration. Yes.
So I agree to what you have said. I understand what you are thinking and speaking, but this is a little mistake which has happened from our side. We are sorry
शुभ्रा
for
ये
that.
No,
ये
it
वो
is not.
डॉक्टर ने बहुत गलत कर दिया है. क्या हुआ उसको? हमारा
वो
वो तो
गलत
क्या
हो,
देखना पड़ेगा
बट
ना.
वो ठीक है. वो मैं आपको एश्योर कर रहा हूँ, उसको कोई प्रॉब्लम परमानेंट नहीं हुआ. वो थोड़ा सा
नहीं,
उसको
आपने एक्स्ट्रा सर्जरी कर दिया तो फिर प्रॉब्लम तो होगा ना, उसकी
नहीं है.
रिकवरी
दैट
भी
आई एम
होगी.
एश्योरिंग यू.
उसका
उसको कोई
वुंड वुंड
प्रॉब्लम आगे नहीं होगा.
वुंड क्लियरेंस और सब कुछ वुंड हीलिंग होना बहुत टाइम लगता है ना
हो
सर.
जाएगा. वो सब हमारा काम है. हम लोग पूरा उसमें वी विल फुली में देखेंगे कि वो ठीक हो जाए. उसका कोई परमानेंट डैमेज नहीं. वो हमारा एक डॉक्टर साहब से बाय ए मिस्टेक हमें सर्जरी के लिए ले जाना पड़ा. छोटा सा सर्जरी हुआ है, उससे उसको कोई हार्म नहीं हुआ है, लेकिन हम एडमिट करते हैं हमारी तरफ से ये
नहीं
गलती.
नहीं, वी वांट अ पब्लिक स्टेटमेंट सर. इस तरह नहीं, आप तो किसी
शुभ्रा
का भी कोई भी
शुभ्रा पापा
सर्जरी
को
कर.
बोलेंगे और हमारे रिलेटिव्स को भी बोलेंगे,
हाँ,
फिर मीडिया को
वी
भी.
विल फाइल अ केस और वी
वी
वांट अ
विल फाइल अ
पब्लिक
केस. हाँ.
स्टेटमेंट और अ रिलीज,
यू आर
प्रेस रिलीज
एब्सोल्युटली,
फ्रॉम योर साइड.
आप बिल्कुल ठीक बोल रहे हैं. यू आर राइट इन वॉट एवर यू
And
आर
we will not pay for all the surgeries and
नॉट
everything
रिक्वायर्ड.
that you are
आपको
doing.
यू डोंट हैव टू एब्सोल्युटली पे एनीथिंग, and it is on us
The
that
pa-
he goes
but
getting.
sir, but the pain, how much my brother is getting in the surgery, in the
No, that
procedure,
pain
that
we are
is not
taking care of.
bearable, na, sir.
That I
Because
am
he came
assuring
only
you.
for the laceration, and they told the doctors, ER doctors also, that there is no need of any surgeries. And then how come it happened like that, sir?
That's it. It's a mistake which has happened, but he's not in pain. His pain is being taken care of. His medical
Shubhra, we
treatment.
need to
आप
take this
कैसे
as
कह
serious,
सकते हैं?
Shubhra.
यस 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 सर, ये आप कैसे कह सकते हैं? रिकवरी तो पेरेंट्स और फैमिली ने देखनी है कि पेन उतना कितना हो रहा है इंडिविजुअल
देख
को.
लीजिए.
आपने
यार वो
अननेसेसरी, अगर हड्डी टूटी नहीं है, आपने सर्जरी करी, आपके सर्जन को पता ही नहीं चला अंदर हड्डी टूटी नहीं हुई है.
वो एक गलती है. इट इज अ मिस्टेक, जेन्युइन मिस्टेक हुआ है. हम एडमिट कर रहे हैं, लेकिन आपका ब्रदर ठीक है. और
Okay.
हम देख रहे हैं कि उसका कोई फीस नहीं लगेगा और बिल्कुल घर ठीक ठाक जाएगा. आप मिल सकते हैं. इज एब्सोल्युटली विदाउट एनी पेन. वी आर
नहीं
Sir,
नहीं, इस तरह नहीं ना. यू हैव
सर
टू.
हायर अथॉरिटीज को बुलाओ, सर एमएस को बुलाओ, और हॉस्पिटल
बिल्कुल.
इंचार्ज
आप
को
जिससे
बुलाओ
भी
सर. हम
मिलना
लोग
है,
उनसे बात करेंगे
वी सी
कैसा है,
दैट
ये
आवर
कैसा
एमएस
कर
आल्सो
सकता है
स्पीक टू
लोग.
यू. यू आर आल्सो फ्री टू फाइल अ केस.
We are keeping
Absolutely.
hope on this hospital, and we are came in the emergency time, but this has happened means the treatment, and then my brother's health is very important to us.
Yes,
It's
and what if
important
the
to us also.
surgery would have really ended up in a disaster? We
It is
want a
not.
written statement from the treating doctor,
We
physician.
will give you a written statement of what has happened. We apologize. He is going to go home absolutely normal, fit person.
Sir, apologize is not the matter, na sir. So like there is a we need a Subra, we need to file a case against this,
Yes,
and
yes, yes. And what
we need to
about the
compensate, or
recovery
we
time?
need to
Matlab,
like,
yes,
Recovery,
because
you
he
see
can't go
now
for the
another
office for 1 or 2
3 4
months. He
days,
can't go to the office
three
by
we
four
want
himself.
days he will
compensation
be.
as well. उसका इतना time loss होगा, सब कुछ होगा, and plus this is negligence, medical
And
negligence.
he is the feeder
And
for his family. and he
Yes.
can't going to the office, and there is also problem to the family also. They need to take care of his family people.
आप
So the
लोगों ने
medical
मजाक
part,
बनाया है. This should be an example. No, people should know that your hospital can treat a simple stitching, suturing surgery instead of a fracture, and you're just messing everything up. And at least somebody has to be answerable.
so we are answerable, and I assure you ki what this mistake has happened, we look into it. We'll personally see why it has happened, and we will have corrective actions in future so that nobody undergoes it, and we'll see that your brother is treated well and he goes home well. That is all
We
assurance.
want immediate suspension of the doctor, a press conference from the hospital. You have to confess to the media that your hospital has done something such disastrous. It could
Shubhra,
have
we will
any
speak with
consequence.
hospital MS and like
So
Yes,
the
CEO
MS
or
will be
COO,
will
we
be
will
yes,
call
yes,
him.
addressing you.
Kindly
yes,
call, sir.
If there are
right.
concerns, the MS will be addressing you. We'll see whether any compensation for this part of his missing his work,
But this is
whether
serious, sir.
the
This is
hospital
because
can
my
give to
brother
you.
is the one
We
and
will
only who is taking care of us. Like he is the feeder for us,
we
and
will see
he
whether
will
any
be
compensation
very
to that effect
this
our
thing, sir.
hospital is able
If
to
he is
No,
give.
in
no, your
hospital for some
attitude
more
is
days,
very relaxed, like you're not guilty of doing a wrong surgery on a patient. This is not how, like, these people are so important for their families. It looks as if it is a routine procedure for you. Okay, we have done a wrong surgery. There's nothing wrong with that.
No, it is a
Shubhra,
wrong
we will
thing.
go for the
No,
media, Shubhra.
Yes,
it's
of
a
course.
wrong thing. We are agreeing it's a wrong thing. We are not taking it casually. It's a very serious things happen. We are admitting to the fault, but we are also seeing that he gets the best help. He goes back home. There's no permanent damage. And any compensation that you think, we would discuss with the hospital administration and see what can be done. And we'll see in future such things are not repeated. We'll put a
Okay,
post.
sir. We'll call up your MS and HCO or COO.
MS
Yes,
will
yes.
personally will be meeting you. I've already informed to him he'll be coming. If you could
Anyway,
wait.
we are discussing this one thing, and we'll call up our MS and
Yes,
HCO.
surely he will be
Yes.
addressing to you.
Okay, thank you. Thank you. Can I request everyone to come in?
Jacob, sir, sorry, and Shubhra, thank you.
Sorry, Jacob. Dr.
No,
Matthews,
that's fine.
really
I
sorry.
acted like good patients actually.
But you appeared very calm and composed. I will compensate you. I will give you everything. I wish hospitals come forward and compensate like this. Then I think people will be very happy with the hospitals, not for treatment but for compensation. Okay. So how was it being there, Dr. Malik, Dr. Matthews, being in that position?
It's not easy. Absolutely, it's not easy because you have committed a very serious thing, and if there was already a fracture and you're doing a wrong thing, corrective surgery is still acceptable. Here, there's no fracture. You're
Mhm.
taking a wrong patient. It's not absolutely, it's very difficult position.
Very. But you appeared very calm, very composed, and you were handling as though it's like fine.
Yeah, but
No?
that's the way you have to do it. I guess you can't show turmoil
But can
and
we really compensate like this? I mean, are we very liberal with this approach, with compensation and apologizing?
but that is the way forward, I guess. It's a difficult thing to do, but if we have done a mistake, we should. Why not?
But at times they ask for inappropriate compensation because they
Then
know they
maybe then we should allow them to file a suit and then take it to court. Let it be compensated in the correct way. Then maybe.
great. So what do others say? If you raise your hand and then maybe I can request all of you to unmute your device and speak one by one. Dr. Manjusha, what is your opinion on the same?
Ma'am, this is a very difficult situation. I think Matthew sir was really calm on handling,
Yeah.
but maybe I'll disagree on the compensation part because putting that compensation firsthand, uh, you get two types of people. Actually, I've had an incident where a wrong vaccination was given. At that point of time, though the department, including myself, we were of the opinion that we should be disclosing. Our management said, for the time being, let's see if something goes haywire, will interfere. And uh, as expected, it went wrong. And then they came back to us, threatening us that they'll sue us because, and at that point, the parents said, if you had told us initially, we would not have made such a problem. Now you did two things, you did the wrong thing and you hid it also. So that was their concern. So it is very difficult handling such situations. And again, I think instead of making decisions on our own, when if suppose I am the physician and I've done something wrong, instead of making the decision, I think it's better to show them the way up to the top management so that they can handle it in a better way. Because there'll be a tendency to manhandle the doctor. So best I think is just saying that we have done this and then telling them you have an option to file a complaint with the top management and help relations officer helps them out to do the same.
So maybe you will escalate the case as
You were
well.
great.
Yeah, great. Yeah, yeah. So any other input, Mr. Kumar, in your hospital, how do you manage such situations?
In my this thing, actually, I am the operations head now. My doctor will call me like, Kumar, this has happened like this. So actually, I'll call the attenders and I'll speak with them for some time. After that, I'll call my MS. Later, if anything like compensation, till that I didn't went anytime. I'll only go for the I'll compromise the patients or some people.
Calming them down, calming them
Yes.
down.
Otherwise, I'll prolong the issue so that some people will realize that, and I'll catch out one person who will listen the things in that group. So
Who
that
will
I'll
agree
call,
with your point of view and your point.
yes, and I'll call that person and I'll take up some issue to my HCOO or like that. And most of the thing, I'll calm down the issue, man. Suppose if the time goes some more time, the patients will get calmed down.
Yeah, if you give them little time, it actually
they will realize the things.
Plus,
The
they
heat has to be get down, man. Then it can be.
Somebody should listen to their problem. Somebody should
Yes.
Understand their concern.
Yes.
That's true. Okay, so admitting that error has happened is okay, or not admitting the error is okay. What do everybody think?
Admitting the error in a manner that we should not get stuck in that any point.
Legal this thing. No. But then that's not possible. That's not possible. Either you have done it or you have not done it.
Somewhere we need to compromise for one thing. For minor things, we need to compromise. So that compensation till that like then they will rise beyond the limit. They will ask beyond the limit.
So there is no one-line answer to it, I believe, isn't it? What do Dr. Deepa says? Is there one-line answer that admitting to error is okay or not okay?
I think it's okay in a correct way.
Yeah, if they can know, if you try to cover it, like Dr. Manjusha said, the family was unhappy, one, because you did not come out honestly in the beginning. If you had informed us, probably we wouldn't have been this badly hurt. The second reason, and studies have shown, I'll be sharing some studies with you that have shown that when you try to cover up and not tell them the truth, they get agitated and that they make it a point to make you tell the truth. So that becomes actually, that goes against us if you don't admit. On the contrary, if you admit, yes, there will be a reaction immediately, but then slowly they would calm down and they would try to now see what can be done. Like if you remember that DABDA, that acronym that we had discussed in Breaking Bad News. So first is initial, and then is anger and aggression, and then is bargaining. Then they'll say, okay, what best can be done? How can we save the patient? How can we save the situation? And then they will try to see what best is being done and can be done in the patient's case. So definitely it's not something easy and there is no one line answer to it. But ultimately getting ready for it, being prepared for it is very important because this can happen to anybody at any point of time. And we normally say that such situation should be handled by senior most person. But there's a possibility that this has happened when there is nobody senior around. And it's the junior doctor or it is the nurse who has to talk about it, because if an error has happened by a nurse, it will be probably the nurse or the senior nurse or the nursing in charge who will have to do the talking to the family, or maybe the doctor in charge. So it can be any way. So that means, I mean, we can't say that it's only the senior person's responsibility. It's everybody who needs to be ready and be prepared to handle something like this. So, any other observation from the situation, Dr. Purnima? Would you like to add something to the discussion?
Yes, ma'am, if I may. It was very well conducted role play, first of all. And the Shubhra has brought out, and also sir has brought out all the points which a patient is likely to, sort of take a threatening attitude, because they also take advantage of the situation. If I'm permitted, I would like to just tell you that what I would think is the way to go about it, which sir also has done the same way. The first thing is talk about the good things first. That yes, your patient is stable. So ease them into the conversation. Talk about the positive point first, that he had multiple injuries, for example. Most of them have been attended to. He's stable now. However, this is what has happened. And then be transparent, but see how much you are disclosing. What corrective action you have planned, corrective and preventive action in the future, that also you should highlight. And yes, if they start threatening you, or because they will take advantage also of that situation, don't commit to anything. Yes, we will do this, we'll do this, also we'll do. We will look into it, or be non-committal, and don't be specific about it, and don't give in to threats. And of course, do keep your backup ready so that you are safe in every such situation. And do protect your staff, but do have a corrective and preventive action session later on. Thank you, ma'am.
Thank you. Yeah, I completely agree. Immediately agreeing to compensation means they will kind of start thinking, now how much should we ask? And then there's no end to it. There's no limit to it. And I mean, then others who are, overseeing this, they may also get inspired. Okay, let me also try some bargaining with them. So that has to be done very carefully. And very rightly said, if we escalate it to the senior management, one, you get time. Second, we are able to read the situation more closely, and then also, so let somebody else do the talking about the compensation or all other aspects. Absolutely, I agree with you. So what happens? It's actually honestly not very easy. Even very senior clinicians, find it very hard to disclose it, and we have seen it is not the way we have done the role play. It doesn't go that way. Usually, there's a lot of tussle between people. A lot of time in surgery, we have seen the surgeon would say anesthetist should go and talk about the whatever has happened, breaking bad news or error, or and and the anesthetist says it's not me who has done it, so it should be you who should be going and talking, and they would have a tug of war between them. And we have seen something like this a lot of time in the hospital. So that means each one of us need to be prepared and should know how do we go about doing it. And at this point, I think discussion about how it happens and what are the challenges will really give us a deeper insight into the situation. Some of you have shared your experience, but I'm glad that you could handle it, you could talk about it, and you could manage this situation. But as I mentioned earlier, also it causes a lot of distress to the person. So we normally say in such a situation, the person who has committed an error, or under whose this thing error has happened, that person becomes the second victim, because they are also now facing the situation. It brings in a lot of embarrassment, and there's a possibility of aggressive reaction and risk of litigation coming from the patient party. And even very seasoned doctors find it very difficult to communicate the medical error. So if you look at what people consider as error, even probably among us also, lot of us are not very clear what exactly we mean by error, and it will help us to know what exactly is error. For example, uh, medical error is exactly when error has happened at our end, where probably we missed to do the right diagnosis, or there was a treatment mistake, or there was a lapse in the health care delivery, and it led to some harm or no harm to the patient. Whether harm happened or not, that's immaterial, but then did the error happen? So, for example, if the patient is mistaken for another patient and getting wrong treatment, like for example, the role play that we did just now, that's definitely a medical error. That's definitely a identification error. So that's an error. But at the same time, a lot of time we miss to do something that's required to do. So you did not take the correct action, the expected action from a professional, be it a doctor, be it a nurse, be it a physiotherapist, be it a dietitian. So if you miss to do that, automatically you are missing on something that is necessary for the patient care. It could lead to harm. It may not lead to harm, but then that's omission. For example, if there's a patient who is complaining of excessive bleeding, and we fail to attend to the complaint, we fail to watch the patient, we fail to check the vitals and the amount of bleeding, and then ultimately the patient ends up into PPH. If you remember, I had shared this case with all of you in one of the programs, in one of the sessions. And unfortunately, we lost that lady because of PPH in that case. And that's also a real life case. Most of the cases I discuss here are real life cases, either I have seen or I have been shared by some of the participants. So that's actually an occasion where we miss to attend to the patient complaint. The third thing is complication. That is something unexpected happen, during or after the treatment or illness, which actually worsened the patient condition, and it created new health, challenges. So maybe an example of it is a patient who underwent cesarean section and she developed postmortem hemorrhage due to uterine ectomy. Or it could be like the case I was talking about, amniotic fluid embolism. So that is documented complication, though it doesn't happen very often, but that's one of the documented complication. If something like that happens, it is not something that we have created, but that can happen, in a situation. And fourth is unanticipated outcome. When an unexpected, result from the medical care that we have provided, it differs from what was intended or predicted and leading to the harm. So again, this was something unanticipated. For example, that case of amniotic fluid embolism. So according to us, all these four definitions are different. But if you will look at it from the patient's point of view, the patient's definition of error is very broad. They will consider all these complication, unanticipated outcome, actual error or omission, everything will be a kind of error according to the patient and patient party. That will also include something that has not led to any harm or something that was not preventable. For example, amniotic fluid embolism is something that is very unanticipated, but they will consider that also as a harm or as a error and all. Patients also consider poor communication from our side or poor service as an error. Whereas if we look at the definition from our point of view, our definition of error is very narrow. It is only when we deviate from the accepted standard of care, it is considered as error according to us. Now, coming to the expectation of disclosure, patients expect disclosure of all errors, including near misses. Even if the patient has not received any harm or anything has happened to the patient party expects even that to be shared with them. Whereas we know we would like to only talk about error that has caused significant harm and very honestly something that we cannot cover. So that has to be shared with the patient party and their family member. Now, how should the disclosure of error happen? Patients prefer it should be done truthfully and compassionately. So we expect transparency and frank disclosure of whatever has happened. Whereas we prefer minimal disclosure, only what is important or only what is relevant. Now, when to have the conversation? Patients want it to happen immediately, whereas on our end, we want to, gain some time. We want to have all the facts. We want to have all the information so that whatever we are asked, we should be able to explain and answer them. And therefore, we prefer to get some time of the same. But on the other side, the patient party is very anxious, especially if they get to know that the patient condition is not stable or patient needs ICU admission or patient is, not doing well. So they would want immediate explanation from the hospital authorities or from the treating doctor. Now, coming to the role of apology. Now, what do you say? Should we apologize? Should we apologize? Write yes or no in the chat box. Let's see. How many of you think that yes, we should apologize or not apologize? Yes, agree. So many of you say yes. Okay, guarded apology. It's very difficult to actually define guarded apology, but yes, I know there is always a it's a double-edged sword. Yeah, I agree completely. So yes, somewhere we feel it, but honestly, in most of the cases, it is seen The moment you apologize, you have actually kind of disarmed them, because that's what they are looking for. And if they get it, at least they know that, yes, we have accepted that error has happened. So if you saw Dr. Matthews very, very nicely, he said a small error has happened, a little error has happened at our end. And then he apologized for that. So that means there has to be apology coming from us, because that's what will give them satisfaction, that we are with them and we are feeling sorry for what has happened. But at the same time, we are concerned that apology can create a legal liability. That's why probably Dr. Purnima is saying guarded apology. I would like to understand it more, from you after I. So when it comes to disclosure gap, 90% of the doctors support, yes, it should be disclosed. Even in your answers, you have said that yes, it should be, but only 30% of the people actually disclose, because we know the repercussions of disclosure. Studies have also shown that almost in 2/3 of the cases, the errors are not reported and they are not disclosed to the patient and the family. Even if the disclosure happens, it does not meet the patient expectation, because they want more details, they want more explanation, there are a number of questions to ask and some answers to receive. And when that does not happen, they do not feel satisfied with the interaction or the dialogue they have with the doctor. And we all know that we do not have any formal training on disclosure of medical error. I think most of us, whatever we have learned, is by observing the seniors. So if you had a senior who could do it well in a professional manner, maybe you'd have learned from them. But most of the people learn by doing, and it's like trial and method. So what do patients expect? What do you think patients expect when we have a dialogue with them? What do you think they expect? Write in the chat box. Transparency, truth. Okay, agreed. They expect honesty, implication of the error. Yes, what is going to be the impact of the error? Absolutely. Be truthful, compassionate, find a solution to the mistake. Absolutely. And take care of their bills. Yes, that's another, bone of contention. I agree. And that's what is probably the most stressing factor for them. A lot of time I've seen in case if the patient requires corrective surgery, we don't hesitate charging the patient for the corrective surgery. I've seen this happening. So I'm not surprised when they expect that why should I be paying for the corrective surgery for the error that has happened at your end. So they need correct information and emotional support, okay, including bill. Support both emotional steps to go forward. They want to be heard. They are actually scared. So we need to protect them, and they also want the bill to be looked after. How it will affect them, they want to know. Then apology, truth, reality, discount, and be truthful, compassionate, find a solution to the mistake, and take care of their bill. Yeah. Whether the length of the stay will be extended. Yes, I think that is an important point. How much time will it take to recover? How many days will the patient have to be in the hospital or even take bed rest? So that can definitely be their concern, and especially if the person is working or has some plan to travel or to go somewhere. And if this hampers their future plan, definitely they'll have a lot of questions. So Dr. Costa says transparency, open communication. You can go back to the doctor and queries and follow. So that means patients first of all expect the statement that error has happened. The more you will try to avoid it, more chances are that they will push you. They will ask you, did the error happen? Please tell me, did the error happen? So first thing that they will ask you is, did the error happen? Then they want to know the details. Details like full disclosure of whatever has happened. And then, like many of you have mentioned, implication to their health. What is going to be the harm or the effect of the procedure done or not done, or the failure of treatment? Will the patient recover? Will it have any long-term consequences? Will it lead to any permanent disability or complication? And then they also want to know who is responsible for it. They really want to have a person or the name or the face for the person who has made a mistake. So they want to know who is responsible for the same. And also, why did it happen? Why did it happen? And and how will the reoccurrence be prevented? Because they say, okay, we got to know. What about those cases we will never get to know? So how will you prevent this from happening to me? And like I said, common thing they ask is apology, and that's what they expect from us. By the way, why don't we disclose? What is the hesitation in disclosing? And Dr. Purnima has added a point. Hence, first explanation should be very factual and limited to the fact sharing. Absolutely. So that's what you said, guarded sharing and guarded apology. But, yeah. Whether length of stay will extend as time passes and they absorb and discuss among themselves, just translate it. Yeah. So what do you say? Why don't we disclose? What stops us from disclosing to the family? Fear of aggression, absolutely. Fear of litigation. Physical backlash, yes, physical bashing. As we know, the patient and the family can become aggressive. And then legal, we fear legal action and we don't disclose because we ourselves feel remorse and fear. Yeah, that is also true. We feel somewhere sorry and sometimes ashamed and also guilty for the error that has happened in patient care. And then what else? Fear of immediate reaction of the family. Very true. A lot of times they react very aggressively. Absolutely. Reputation of institution and reputation of the person also. Sometimes even institutional pressure stops you from sharing. They would stop you to share because they know their hospitals, reputation is on stake. Then fear of unknown and how the relative will react. Yeah, because they may act aggressively. And diplomatic answer, if we admit fair faults, as this might lead to defamation of the doctor, hospital exemption from patients and financial compensation. So how is it diplomatic answer? It's the correct answer, Parvi, because that's true. That's what is on their mind. I agree, no healer intends to harm, but error happens sometimes when we don't follow the protocols and we don't follow the system. So it's not a willful error, but then omission is also an error where we fail to perform our duty. Yes, if there is no clear policy on disclosure, there is a possibility we might hesitate to admit. Yes, negligence is yes one. Okay, I meant if we don't give diplomatic answer and admit that the mistake openly, yes, I agree. Yeah, and then lack of back-end support. This is very correct, Shubhra. A lot of time you want to come out, but you don't get the support from your seniors or department or head of the department, and then you don't know how do I handle this, and then there's no, even legal support to help you. Very true, and lack of support from admin and need to write incident report. Yeah, I've seen in I was taking a program for a group of nurses. So one of them admitted that there was some error that happened in the OT, and she wanted to write in her nurse's notes that this is what has happened in the OT. She was pressurized by the doctors, you can't write this, you will have to delete it and you will have to tear this page. And she did it actually. Because she was a new nurse and like not very old and experienced. And even if she was old and experienced, we know the kind of pressure we exert on them. So she deleted her, report. So there is always a kind of a pressure on the staff to not to disclose. So most of the points have been covered. Let's see what this says. A lot of time we are skeptical of benefits. What is the use of telling? It has to be managed. We will manage. What is the point of telling them? People think like this, or they don't think that the patient need to know about it. Then sometimes people think that disclosure is unnecessary because it will unnecessarily cause distress to the patient and family, and we should be able to manage on our own, and there is no need to disclose to them. And then especially when we know the patient is unlikely to find out, all the more there's a possibility that people would not disclose to the patient unless there is some side effect, unless there is some reaction. So we know the patient will not get to know. Of course, fear of retribution from patient and colleague is one of the reason. Fear of legal action and financial judgment, we know, is also very, very common. Fear of having to handle the patient's emotions, because it's very unpredictable. Somebody might start fighting, somebody might become aggressive, somebody might breaking things. So you don't know how the person or the patient or the family might react emotionally. And if we are not prepared to handle and we don't have the back end support, we are very scared to handle it. So as I was mentioning in the last class also, when I took this session with doctors from Afghanistan, I was talking, we did cover this topic with them. They were telling me, ma'am, if we admit this, gone, we are gone case. So there is no possibility of, we coming out and saying that this has happened. So I very well understand. So if you have a clientele who is very aggressive, we know there are certain communities who are very prone to becoming aggressive and violent, and they start destructing and destroying things. So definitely I know there will be a kind of a fear that they can react anyway. And then sometimes people think that disclosure is more like a factual conversation, and there is no need to get into the emotions and explanation and dialogue and then answering their questions. And sometimes people think that the outcome is not related to the action on the part of the person disclosing. So there is no need to disclose it to the patient or their family member. And of course, we all know there's lack of training in error disclosure. So people are not very comfortable doing this with the patient or their family. So are there any benefits? Are there any benefits of disclosure? If yes, what do you think are the benefits? What are the benefits of disclosure? Write in the chat box, please. Okay, moral contentment. You feel that I have ethically practiced. Credibility. So it doesn't come as a surprise. Okay, admitting mistakes can disarm the relatives and reduce the chance of legal issues. That's true for me, I agree. Honesty. Yes, you want to practice honesty. Dr. Manjusha says increased trust become easier further instead of excuses over excuses. And then, of course, peace of mind and ethical. Yeah, if you cover up, you have to go online telling lie. So it becomes sometimes endless to stop telling lie. And if the situation escalates or leaks, it is a preventive measure also. Then being a reliable and truth health organization, that's very important. Mental relief, yes. When you tell the truth, you know that you have kind of told everything and there's nothing that you have hidden. So trust the corrective action by team and its follow-up and upholds credibility of the team. Yeah. And then even if legal action is taken, the courts accept apology, and if you have taken corrective measures, the court do consider that. Again, it depends on the seriousness of the situation. There's no one-line answer to it, but yes, apology do softens the case and make it easy. And I have number of studies to show you where apology has actually had to handle the situation. And then where are we? The suppression can backfire badly. That's very true, Dr. Purnima. I mean, number of studies have shown sometimes patients, just to take revenge and to know the information, they sue the hospital or the doctors because they feel somewhere the information has been kind of hidden from them and they have not, that has not been shared with them. So they kind of take it as a point to prove that there is something that you are not. So definitely one of the benefit of disclosure is it promotes transparency and it builds trust. Especially if you have been taking care of the patient very well, you have acted as a very professional healthcare provider. And in case if an error happens and if you admit them honestly, mostly they respect and admire your transparency, and it will further build trust with them. It will also enhance patient safety, preventing future incidents. I think that's very important. See, when we make a mistake and we don't tell anybody, neither to our team or to our seniors or to the patient or their family member, there is a possibility the same error may be happening by others. But nobody is admitting, nobody is sharing, nobody is telling. So automatically the future incidents will not stop. But once it is brought to the knowledge and information of the team and the stakeholders, at least root cause analysis can be done, and the kappa can be implemented, where you take a corrective action and preventive action, that at least future cases can be prevented. Like I said, this, that if you will share this with your team and tell them whatever has happened, you will be able to improve the quality of care by using RCA and kappa. And then, of course, the legal requirement and the ethical requirement is that we need to share with the patient. If you look at the patient's right, patient has all the right to know about whatever has happened in their care. And if we are not sharing that, even that's also encroachment on the patient's right. And it definitely strengthens patient-provider relationship, because they will have more trust in you and they'll see you as a professional healthcare provider. It facilitates healing and recovery, and it provides support to the patient and family. So, for example, an error has happened. If the patient does not know, patient may not take the precaution or the care the patient is supposed to be taking. As a result, there may be compromised outcome. On the other hand, if you have explained that by mistake, for example, if you have given a double dose of sedative, let's take a example, and you know that the patient will feel drowsy, and patient can get injured by falling, or in case if they drive, there's a possibility that they can meet with an accident. But if you tell them that this is what has happened, and for the next maybe 24 to 48 hours the patient should not be driving or should not be going alone and should not be left alone, so definitely it will not only prevent further harm to the patient, but it will rather facilitate the healing and recovery of the patient, and it will provide support to the patient and the family. At the same time, studies have shown that if you are able to have a skillful conversation with the patient party, most of the cases can be handled well. Only 3 to 5% of the patients injured by negligence actually sue the doctor or the hospital. So I think this should be kind of a very encouraging picture if you know how to do the disclosure. But before that, I think one prerequisite, am I acting as a responsible professional? Am I looking after my patient responsibly? That plays a very big role. In case if we have not been very careful, if we have not been very attentive, if we have not been listening to their concerns, so that anger actually comes into this situation where they have been able to identify an actual error that has happened at our. Now probably it is their turn to take revenge from us. So in case if you have been able to kind of showcase that you are a very responsible professional, and after that, in case if some error happens, usually when you explain to them in an honest manner, initially there will be reaction, there is a possibility of reaction, but most of them actually, calm down and they accept it with time. So studies have also shown, like I was like Dr. Purnima was talking about. So patients usually, sometimes file the lawsuit not for the negligence, but whenever we have not been able to communicate effectively with them, whenever we have not addressed their concerns, we have not explained to them, or if they see lack of empathy and the feeling that we are not treating them, properly in a careful and a respectful and a compassionate manner, or if there is any perceived or actual withholding of essential information. So anytime if they feel that some information has been, suppressed or hidden from us, so they may decide to, file a lawsuit, because they know in the court of law we will have to come out with all the documents and explanation, and there it is unlikely to hide anything. But most of the times it is because they are not happy and satisfied with the kind of communication we have with them and their family. So I'm going to talk about full disclosure policy. There are a lot of studies on Google search, if you'll see, who have implemented full disclosure. This is one case. This is University of Michigan, where they tried implementing full disclosure policy, and it has 3 components. So in these 3 components, the first one is, if the patient was harmed, they acknowledge it promptly and they compensate the patient quickly and fairly. So if they feel that yes, an error has happened at our end and the patient needs to be compensated, They did not try to cover up. They quickly and fairly compensated the patient. Like Dr. Matthews was saying, that if an error has happened, you have to compensate. So that means if you take that approach, the family somewhere feels that okay, they have made a mistake, but they are ready to cover for it. And if they felt there was no error, or it was just a complication or some unanticipated outcome, they would aggressively defend the case in the court. So they will not accept it as an error. I'm sorry. And the third one is, if there was any adverse event, they studied how to avoid that in future so that those incidents can be reduced and the patient care can be taken care of. And you'll be surprised to know they actually took data in 2001 and then in 2005, and see they could reduce the litigation cost by almost 2/3. The cost of the litigation came down to 1/3. Even the average time to resolve the claims and lawsuit also went to almost like 40%. And the number of claims and lawsuits also reduced almost by 50-60%. So this is what they have implemented. Again, there's no one line answer. Every situation is different, clientele is different, but these figures definitely encourage us to consider that there will be a situation where we will have to come out openly and honestly, and how should we be going about doing it. I'm going to share some guidelines now for disclosure of error. So they are more or less like we do breaking of bad news, or we handle a difficult situation. So these guidelines are actually based on the recommendation from the Canadian Patient Safety Institute and UK's National Patient Safety Agency. You can definitely customize it as per your situation or guidelines, but these are just to give you an idea how you can go about doing it. So the first thing is, this is preparation before you do the conversation with the patient and family. So it's very important to first of all check in and see how are you feeling. Are you ready? Are you ready with the information? Are you ready with the explanation? Do you know complete information? Are you mentally and emotionally ready to handle the situation? Review all available medical facts so that when it comes to explanation, they will definitely ask you a couple of questions. Like, for example, the situation we talked about where there's a fetal distress. So the family might ask you, why did this happen? We came for regular antenatal checkup. Everything was going well. You never said that there's any kind of distress to the baby or to the mother. How could it happen all of a sudden? So if you know the situation, if you know the patient's case well, if you're thorough with your understanding of this subject, you will be ready to explain and answer their questions. There is no harm taking help from your trusted colleagues. You can ask them to be with you in the situation. You can seek their opinion or advice how to go about doing it, or even you could go and do it together. That's also one of the possibility. And also in such a situation, I think though we say it should be done by the senior most person, but juniors can definitely be present to observe, because that's what is how they're going to learn. Then prepare for strong emotions. There will be emotions from the patient party, definitely, and definitely you will also be overwhelmed in this situation. So be mentally ready that I have to kind of handle it calmly and do not lose my composure. When it comes to actually performing the disclosure of medical error, it's always good to sit in a side room, in a counseling room with the patient party, preferably with immediate relatives of the patient who have been through and through with the patient. Preferably have somebody with whom you have already interacted earlier, and if you know them well, if you know their name, if you call them by name, it again builds rapport and also helps you to connect with them. Some of them, I mean, it's not a good idea to do with lot of people around, so it's good to ask maybe 2-3 of you can please come in. I need to share some information with you, and then you sit in the side room. and do the discussion with them. So when it comes to talking about the error, it's always good to begin by stating that there has been an error. Like in the role play we saw initially, he said he's fine, he's doing well, and then he mentioned that there is a small error that has happened at our end. So saying that first that he's fine, but there is a possibility a situation maybe the patient is not fine, maybe the patient is not doing well, so you can't say that patient is fine, so that means you're telling a lie to the patient party. So that, but if the patient is fine and is stable, there's no harm telling that the patient is fine and he's moved to the room, and then but I have some important information to share with you. And then begin by stating that there has been an error. Describe the course of events, that is using simple and non-technical language. So for example, the role play we did, I mean, there's a possibility that there were two patients with the same name, or there's a possibility that another patient's x-rays were attached to this patient's case sheet, and the surgeon did not realize that this patient's name and the name on the x-ray is not same, and he did not check. So it could be like how exactly the error happened. If you can just simply explain them without blaming anybody. Please make sure that you do not blame your staff, your doctors or nurses. Then it becomes, like you don't want to take the responsibility, but you want to blame them for the error. Then state the nature of the mistake and the consequences and the corrective action. So as a result, we missed to, realize that these x-rays were not of this patient. And we assume that your patient has a fracture, and we took the patient to the operation theater for correction of the fracture. And then it's only when we started operating, we realized that there was no fracture. And immediately we closed the case, and then this is what we. So you kind of explain them the nature of mistake, the consequences, and the corrective action that you took. In between, use lot of frequent, pauses. Give them time to understand. Give them time to assimilate. Give them time to comprehend what you have said, because it's a shock for them. So for you, it may be a minor thing, but we have done surgery for your patient. Like if you remember, Mr. Kumar was telling, oh, he had just simple laceration. What was the need for surgery? How could you operate? We had not even given you consent for surgery. So the whole discussion went to altogether a different angle. So that means if you frequently pause, you're giving them time to not only understand, comprehend, accept, but also, ask questions. And it's very useful to allow them to ask, and give them a chance to ask. So if you saw the number of questions both of them were asking more about, you didn't take consent, how could you do this surgery? We will not pay you for it. What about the recovery? We are going to file a case. Then compensation, negligence. So you see, all these when they were coming out, that means they are thinking on these lines. In a way, you will get an insight into what are they thinking on, or what all can they consider doing. So it's good to give them a chance to ask. And if they ask you questions, answer those questions honestly. Because at this point, if you try to cover up, now they are going to argue with you and fight to prove that you are hiding something from you. Coming to the apology, I know some of us are not comfortable with the idea of apology, but usually sorry works, especially when it comes out as a personal regret and apology. They feel that you are understanding that we have harmed the patient or we have done something. But if you can take their focus to the patient's welfare or whatever corrective action you are going to do or you have taken, their shift focuses. Their focus shifts to the patient's welfare. And if you can, have that kind of, skillful conversation where you immediately move to what you are going to do to correct it or to prevent further harm and look after the patient. So there are two meanings of apology. I think we have discussed this earlier, but I just quickly go through it. The first is the expression of compassion. For example, if something happened to the patient but it didn't harm, but definitely it's an expression of compassion. But if there is something that has happened and it harmed the patient, then of course it will be taking the responsibility. But lot of studies have shown, see, legal responsibility or not legal responsibility will take a longer, time to prove. But definitely, momentarily in that situation, it helps to calm them down. A lot of time we offer an apology, but it is not a good way of doing. So it fails. For example, when you say if there was an error, then definitely we will take an action. That means you don't trust and you are not convinced that error has happened. Yeah, there was a mistake, but it did not harm the patient. So when you say something like this, again, you are saying it did not harm the patient, so why it's not a big deal. That's not a good way of giving explanation. The mistake certainly did not change the outcome. See, your patient condition was as it is very serious. He was not going to make it. Unfortunately, this has happened, but that wouldn't have changed the outcome. Again, that's not going to be a very good way of apologizing. And sometimes these things happen, especially if there are a lot of patients and there's a lot of chaos. The emergency department is usually very chaotic. So there is a mixing of case sheet, and that's what happened in your case. I'm sorry, that explanation will not work, and that will not work. So best would be taking responsibility. Wherever possible, use I statement. They will feel that you are taking responsibility, and avoid blaming your staff or your team, and avoid even speculating, oh, this maybe this happened, maybe that happened. I think that will not really help us. Again, at this stage, invite questions, ask them what are their concerns, anything they want to know in detail, anything they want to be explained more, whatever their concerns are. I think they need to be invited and asked and answered. Now, once you have explained them everything, it's important to make a follow-up plan, because definitely after this, after informing them, you are going to go and work on stabilizing the patient. Or maybe your team is already stabilizing the patient, they're already working on the patient. So they will have some questions to clarify with you later. They may want to meet you, they may want to see the patient, they may want to even seek second opinion. So it's important to make a follow-up plan with them, explain them what you are going to do to stabilize the patient or to minimize the damage, and what kappa you're going to do for future. Then how are you going to meet their needs? For example, if they want to meet the patient, when and how you will make sure that they are able to see the patient. Or maybe they want to go for a second opinion, how will you facilitate that? Then plan for the next update, especially if the condition is really unstable, or the patient has been moved to ICU. So definitely very frequently they would expect us to tell them how is the patient doing. Now the patient is better, patient is responding to the treatment, or the BP is fine now, the patient is conscious now, whatever the changes are. And they would like to, not like after 3 hours or 4 hours or 6 hours, maybe every half an hour they would like to be updated. So in that situation, you'll have to give them a chance that, okay, I will be, or I or one of my team member will keep updating you, about the patient condition. And very important here is remain accessible. Lot of time people, after disclosing the error, they switch off their phone, or they don't pick up the phone, or they don't come and meet the patient's family. That kind of again agitates them, and they feel that you are acting irresponsible. In these hours you have to be accessible, because something has gone wrong with the patient, or a patient has been harmed because of our team or one of the team member. So somebody should be there to answer their questions or explain to them. And doing anything like switching off the phone or not taking their call is very very unfair. I remember there was one case, it happened long ago. I was reading that in the newspaper. That happened in Bombay. After the doctor explained the when before that he had very cordial relation with the patient and the family. But after the surgery, I think something went wrong, and he announced to the patient. After that, he did not visit the patient at the time, and unfortunately, the patient died after that. Can you believe that husband of that patient actually sued the hospital and the doctor, and that case went on for years, years. And then there was a verdict, announced after, I think, lot of time. If this case was there, it's still there on Google, if you will Google search. It was some surgeon, I think, who. So it really agitates the family, and they sometimes become, revengeful with the thing. Now, once you have handled the situation, once you have talked to them, explained them, it's very important to document your conversation, because that comes as an evidence that you have informed the family. So make sure that you report the incident. Most of the hospitals have some format. If you don't have, create a simple format to write or document the disclosure of medical error. But in all probabilities, this should be documented, and whatever actions you took, that also need to be, written briefly, so that you make a mention of whatever actions have been taken by you or your team. So whatever was the rationale for the clinical decisions you took at that moment, even that can be mentioned to clarify for your decision. Then whatever was the clinical outcome and the further plan of care, that needs to be documented. Whatever discussion you had with patient and the family, who was present, name of the person, and the relationship, to the patient, and the questions they asked and the answers you gave. If all those can be briefly, mentioned in the report, it will be helpful for a person who reads it later to see what has been, communicated to the family. After the situation is over, it's very helpful to sit and reflect. As I said, it's a very overwhelming kind of an experience. So anybody would be kind of very disturbed after doing something like this. It's good to sit back to check, how are you feeling now? How are you feeling in the situation? And what you could have done differently? Where did the communication go wrong or right? What was appropriate, inappropriate? Just revisit the incident and your conversation with the patient and family, because that's where the real learning lies. It's always useful to discuss with the colleagues. They may give you some more ideas, some more insight into how do you go about managing the situation. Read material to update, because I know this is now happening very frequently, and people are very, alert. They expect us to explain in a more professional manner. So updating yourself on different techniques and tools will give you an idea about doing this in a more practical manner. And then attend programs on, do a lot of mock exercises. I think that would be best. Do a lot of mock exercises in your setup, so that you become comfortable in doing. We did one role play, so you could actually, in your own department, you could plan something, taking simple situation and then difficult situation and complex situation, and then the kind of questions the patient party can ask, that will give you insight on what questions can be asked and what should be the answer. You may not immediately get the exact answer when you are in this situation, but when you're doing a role play or a mock exercise, definitely as a group you can collectively, come up with possible answers that can help you handle the situation effectively. So to quickly summarize what we have discussed, it's important to prepare yourself and state to the patient and the family about what has happened, and accept the mistake. I am happy with the word guarded disclosure. I think I like that definition. I add that in this slide. That will be wonderful. Because and the explanation that you gave, Dr. Purnima, I agree with you. I mean, whatever you say in the first meeting, that will become more like a whatever you have said. So you have to be careful with the facts that you share. So you're not hiding, but you are sharing with care. I agree. And then apology, take responsibility, invite questions, and make follow-up plan together. Document whatever discussion you have had with them, and then make sure that you sit and reflect. 3-4 slides just to focus on how can this be avoided, although they're not part of the disclosure. But I feel somewhere, can we prevent errors? I think if we focus on that, I think we will have to face this kind of situation less often. So I'm sure most of you must be knowing about the Swiss cheese model. And we know in Swiss cheese model, there are checkpoints at every place. And the idea is at least some checkpoint should point us that an error is going to happen. And if that checkpoints alerts, we can actually prevent the error. So if you take this example, for example, the prescriber writes orders for medication to which the patient is allergic. No, usse pehle ye hai, patient is allergic, but patient's history, allergy history is not obtained from the patient. Like you forgot to take the history from the patient. And you prescribed the medicine patient was allergic to. Then the pharmacist also failed to check the patient allergy status and he dispensed the medicine. Nurse gave the medicine to the patient, not realizing and not knowing and not checking whether the patient is allergic to the medicine. And unfortunately, patient arrests and dies. So there were 4 checkpoints. And when all 4 checkpoints were missed or skipped, error happened. So make sure that in your system you create multiple checkpoints. More the number of checkpoints, less likely would have error. Check, check, and check. And if all of us check at our end, I think at some or the other point you will be able to prevent the error. Next is communicate, communicate, communicate. More you communicate with the patient, more you communicate with the family, more you communicate with your team member, more chances of identifying if any error is going to happen. And then practice patient safety measures. Lot of protocols are available for every department. For every situation. Apply those protocols, practice those protocols. You will be able to prevent errors. And then, of course, effective documentation. I think documentation really helps in preventing a lot of errors that happen because of no documentation. So we should all practice it more meticulously. This one book, I think I spoke earlier also once by Dr. Atul Gawande, who is a neurosurgeon practicing in Harvard University. His book is Checklist Manifesto. It's a beautiful book, and he talks about how other, industries are practicing checklist in their industry, and they are able to control errors. Same way, can we create similar checklist in our system and avoid, and or minimize errors? So lesson to learn is establish SOPs for everything and anything that you are doing and follow these protocols. Unfortunately, incidentally, we have protocols for a lot of things now because NABA, JCI, they are all SOP based. But are we really using them? Are we really implementing them? If we are not implementing them, more on paper but not in practice. So make sure that you put them in practice, use those protocols, avoid shortcuts. Wherever we practice shortcut, there is a possibility of error. In surgical safety checklist, if you follow the guidelines given by WHO, in OT, I think you can prevent almost all the errors that happen because of identification failure or similar error. But when you avoid those, I've seen in lot of OTs, nobody follows the checklist, but at the end somebody tick marks and signs it. I don't know what is the point of doing that. That means we are just doing on paper and following the shortcut. So create an environment of open expression where people can come up to you and address and explain and admit that error has happened. And if we do not, actually it's employee safety if you can ensure and if you can give them that psychological safety, they will definitely come up and share with you. And they will report the error. And if you encourage that, and I know a lot of hospitals are now practicing this, they are actually encouraging and rewarding the person who comes up and admits an error or reports an error. And then I think these are 2 simple tools if you can implement in your work situation, RC and CAPA. You are on the path of continuous quality improvement. So although I know disclosure of medical error and these 2 things are not really directly this thing, but I felt that errors have to be prevented. So that's why I thought I must talk about it and train your staff. At the institutional level, it's very important that we start talking about disclosure of medical error. So integrate disclosure of medical error, patient safety, and risk management activities. Do role plays, do mock exercises, do discussions, have these things in maybe during coffee, tea, lunch, talk about it. Then establish a disclosure support system. Like in lot of hospitals. Mr. Vimal, I think your device is on unmute mode. Can I request you to mute your device? Mr. Vimal, please mute your device. Yeah. So we have to have a disclosure support system where we people know that in case if an error happen, whom should I escalate? Whom should I report? What can be done? Rather than hiding or sulking or covering up, is there a way that I can, get help from my system? And then of course for that you need to provide background disclosure education, and then coaching them, training them how to go about doing it, and then providing emotional support for healthcare workers. As I said, it's not just the patient who suffers, it's also the staff who suffers. So create a culture of patient safety, create a culture of employee safety also, and then create a culture where people report errors promptly without the fear of repercussion. So if you do not punish the person, if you do not defame the person, if you don't target the person, if you don't issue any notices and those kind of things, people will come forward and report. The error. And then not only you need to implement disclosure of error, but even how they are doing it, if you can evaluate their performance and help them learn the right way of doing it. I think that's what it needs to be implemented at the institutional level. So this is in brief about disclosure of medical error. We can have the question answers, and then I want to show you two videos on, although the video is not on disclosure of error, the videos are on, it's a case of complication. But I think the situation is similar when the patient party is not mentally ready to hear something like this, how they react and how you handle. So in those videos, I want you to focus on the verbal and non-verbal component of the physician who is doing the conversation with the patient. But before that, if you have any questions, we can take this question or any question or feedback or comment. Dr. Purnima, you had raised your hand. I saw it, but then I missed it. Yeah. If you have anything to say, you can go ahead, please.
I just wanted to add one point, though I'm sorry I did it at a wrong juncture. The fact is that when an error occurs, the medical personnel at who bears the actual responsibility of having committed the error, or the team, they are also not in a very optimal mental state, because nobody really wants to harm their patient, or no one really goes in with an intent to neglect or harm volitionally. So at such a time, just like we have addressed the system of second victim, they also require support. You have covered that in these slides and told us. So at that time, that's why I feel that the lesser that we speak, or rather we limit the information to what is actually necessary, because we tend to overcommit when we are feeling remorse ourselves, or when we are ourselves emotionally and mentally upset. Very soon after the error has occurred, they themselves are in a state of shock, and so that phase has to be, limited communication to the fact things, no overcommitting, and then the situation can be revisited as and when needed. Thank you, ma'am.
Thank you for your feedback. Wonderful. That's a good input. Thank you. Yes, Dr. Mandisha, please go ahead.
I would rather like to share an experience.
Sure.
When I was a resource person for the skill training workshop that Kerala University of Health Sciences had. So there was a ZCOM module, the communication module, in which I was the resource person. So we had one mock, the role play as similar to what we did. So actually the whole crowd was divided into two, where senior doctors were of the opinion that uh, we should not be teaching our for our undergraduates, that they should be disclosing everything, because they felt they would just imbibe the message that whatever error is there, without even thinking over it, they would just go and disclose it to a patient, leading to cases like, as we mentioned, Vandana Das and other cases where manhandling is on the high in Kerala now. So that was the opinion of the senior doctors. The junior doctors, they were actually they were of the opinion if it was a major error which cannot be, kept away from the patient party, you have to disclose them. Small things like, giving a wrong medication, a single dose, which is not going to harm the patient, maybe we should keep quiet. But when you teach your IMGs, how do you tell them this is a major one and this is a very trivial one? So by the time they get the experience, they would have either gone through a lot of these or
Yeah.
they would have been manhandled by the mob. So that
Very
was a very difficult thing.
So I completely, understand what you are trying to say, Dr. Mansha. So therefore, I never say that yes, this is, law and these are the guidelines, so you have to implement it. Because whatever we are, even developing, that's based on the Western information and Western practices, if you ask honestly. And cultural differences are very, very, they're very different in different places. Like I took the example of Afghanistan doctors. They said, ma'am, impossible. If we talk about error, gone case, we are gone. So that's something we can't share. So I understand even in Kerala or in all these states, why only point out Kerala? I think all across the India, that's true. And it's not just India. Even if you look at these studies, 75% of the healthcare professionals have experienced some kind of violence against them, even in the developed countries. It's not just in the developing countries. Because that emotional reaction to the situation is common even among educated societies. So we have to, like I'm telling you, there will be a situation you can't hide at all. At least if you know, you can manage it well. But where I mean, you will have to evaluate. Law says, and law says a lot of things. Are we really exactly 100% implementing what the law says? So, but somebody should know how to go about it. We all should know how to go about handling it. I think that's the message we can give. But of course, there cannot be a clear, yes or no to this. It will have to be, you will have to decide in this situation how you want to handle it. You will see people who are very honest and very, very clear about it. Whatever happens, I'm going to share. That's their call. And we have seen people, I mean, they will fight tooth and nail not to disclose, and they'll cover up and they will make sure that nobody gets to know what has happened. So again, it's individual call. Nobody can say this is right or that's right. So they will have, but the education has to be done, the training has to be done, the preparation has to be done. That should be done that with clarity. What if there's a situation that you have to talk? How will you talk if you don't know? At least put that in their mind. They will at least learn how to go about it. But thank you for adding that observation, and that's a very relevant point that you have brought up. Any other observation or anything you wish to say or ask? So we can see the videos. They're just not very long video. Again, these videos have been done by Indian doctors, so therefore you will be able to relate with them and you will be able to understand the context. But I want you to focus on their verbal and non-verbal conversation with the patient party. Give me a second to share this screen. So first, I'm going to show you the bad disclosure.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no. Is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple, routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given the blood and bleeding is fixed. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see, watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her, but we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
So, since we have talked about verbal and non-verbal communication in detail in all the 10 sessions, so what do you think was inappropriate in this situation? What if you write in the chat box, because it will be easy for us to know from everyone what they felt was it. Doctor not listening, okay. Directly disclosing, abrupt start, okay. Not answering properly, indifferent, sans any compassion, absolutely. Doctor lacked empathy, abruptly ended the discussion. And he's in video counseling. Oh, he's in open. Yeah, he was sitting in the lobby actually. Whole conversation was on negative note. Absolutely, the doctor disclosed the problem in a rash and cold manner, and then the doctor lacked empathy. Absolutely, closed posture, no compassion, speaking facts onto the face, no addressing concern, defensive, no privacy, no definite answer. Absolutely. So we could see that he did the whole discussion, in an open place where there were others who could overhear, and he was, he gave the information as though I've already told you. So I told you this is one of the risk, and this has happened in your case, and I can't. I mean, that's not my responsibility. So even if you have explained to it, but nobody expect something like this to happen. And when you talk like this, it sounds as though I had told you, so that I'm not at fault. And also, if you, like many of you said, his tone of voice was not very kind and compassionate. The body language also did not showcase that he understands that it's a sad news or it's a difficult news for the family to understand. He didn't ask them to ask questions if they have. He was not even ready to answer. And he was interacting with only one person. What happens when you talk to only one person and the other one is completely ignored? The other person can become angry and feel ignored, insulted. And they might instigate the patient's family later that we should sue them, we should put them in place, we should show them their place. And or they may mislead the patient. So it's very important to engage with both of them. Very rightly said by many of you that he left the conversation abruptly. He did not end it in a proper manner. He didn't ask if they have any concern. He didn't share any follow-up plan. He just said, "I'm going to see, and whatever it is, I will let you know." So that means he did not end it in a proper manner. Okay, so let's see the second video. Could he have done it in this manner?
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Unfortunately, I have some bad news to share. We've run into some complications into the surgery and we've had to shift Mrs. Kumar to the ICU. What happened? What complications? Oh no, is she going to be all right? I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually, we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure. But this was supposed to be a simple operation. How could this happen? Well, in order to do this operation, we first have to put a needle into the abdomen to blow gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up. Where did that blood come from? The bleeding was coming from a major artery inside the abdomen, and it appears that the initial needle insertion was responsible for the bleeding. Who put that needle? I put the needle in, and I'm very, very sorry about it. This just was not expected. We are trying our best to minimize the effects of the bleeding. Is she going to be okay? I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can. When can we see her? Well, the ICU doctors are working hard to stabilize her, and as soon as she is stable, we could see her. I will let you know. Do you have any questions for me? Really don't know what to say here. I understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
So I'm sure some of you must be wondering, should he have talked about all that? Should he have shared all that or not? So that's not something I would focus on. That's individual discussion that you have to exercise, individual call. But the law says, yes, it should be shared with the patient's family and the patient. But if you look at the way he conducted himself, it was very calm, composed, humane, enough time to talk, maintain privacy, gave them time to ask questions. I mean, whatever we discussed as a protocol, I think that was displayed in the video. So I think this one example actually, and especially in Indian context, when you see these doctors practicing this gives you an idea that yes, something like this can be done, can be tried. But again, it depends from situation to situation. I can see some answers coming in. The doctor was really patient and explained very well. Yes, thank you. Doctor is cool and polite, giving answers for every question. Absolutely. So clearly, again, as I said, I will not get into the discussion of should he have mentioned all that, should he have given some cover up, explanation. That's not the discussion. But primarily, I wanted you to focus on the body language, tone of voice, the dialogue he had with the family, made them comfortable, explained them properly in simple way, and then assured them of whatever he can do and how will he meet their requirement. So with this, we come to the end of this topic, disclosure of medical error. Any questions or any feedback on the topic or any comment that you want to share with others? I know we have been having discussion throughout this session, so maybe there are not many questions or feedback. With this, we come to the end of the program. This is not the end, this is the beginning of the journey. So I will be sharing 3 forms with all of you. One is, of course, feedback for this particular session. Parvi, 1 second, I'll come to you. One is feedback for this session, then feedback for the program, overall program, and then the post-training assessment. The pre-training assessment we did before the program, and post-training assessment. So 3 forms I will be sharing. Take your time. By end of the day tomorrow, you can complete all the 3 forms. I've tried to keep the forms very simple, but they will be very useful in us in improving the program topics and the overall format. Feel free to give your suggestions and recommendation. And if you want me to remove that name part, if you don't want me to, if you're comfortable sharing your name, I'll be happy. Then I can reconnect with you and take more, understanding your point of view. But if you're hesitant to give your name, then I can remove that mandatory part on it, because if it says required, then it will not let you submit the form. So is it okay if there is name and designation asked? Are you comfortable?
Comfortable.
Sure. Thank you so much. Thank you. So now I would request, I hope you have some feedback to share with all of us. And I was hoping, Meenakshi, are you there? Meenakshi, are you there? So I'm hoping Dr. Agarwal and Dr. Lalu Joseph to join. Parvi, yes, you had something to ask. Go ahead, yeah.
Ma'am, I just had one query.
Mhm.
So, in most circumstances, I have noticed that hospital management, in an attempt to de-escalate the situation,
Mhm.
they try to hide or not fully disclose what exactly happened.
Mm.
So now my question is, when the hospital management actually knows that being honest, or at least being diplomatically honest and revealing what happened, can reduce litigation or can reduce litigation or chances of escalation, why do they not consciously address it, and why do they just try to suppress it?
So, Parvi, I think the clear reason is it's still time for people to realize how disclosure is beneficial. We are very scared of the repercussions it can have. One is, of course, the violence and mob attack. Second, compensation. You never know what kind of compensation the patient party might ask. So nobody wants to compensate. And third, of course, the legal action that they fear, that there can be a legal action. So to avoid that, they want to just skip that. But I'm sure, hopefully, in the time to come, when they will, if somebody comes forward and does that study to see if we don't disclose where we are, and if we disclose how that improves, the hospital reputation and the complications that they face, maybe people will come forward. But I think still the hospital administrators are not ready for that. But then, of course, whether you like it or not, you will have to come out with it. At least,
Ma'am,
yeah.
Ma'am, the studies that you mentioned, where it is stated that 3 to 5%, after complete disclosure, there's only 3 to 5% chances that the patient might escalate it. So those studies are not conducted in India. Those were studies conducted in other countries. So, ma'am, like you said, we don't have research that can give us figures right now. But based on your experience, could you please share how the situation is in India? Whether telling the truth escalates the matter, or whether it de-escalates, specifically referring to the Indian context.
So very honestly, as you said very correctly, we don't have very many studies. People are not open to doing this study at all. A lot of time I tell, hospitals that, okay, we will do a study before training and then after training, what is the change? I remember with one of the ICU doctors, we planned that we will do a study that we train the doctors in how do you update the family and how do you break the bad news. And before that, we will do an assessment of the patient satisfaction and the doctor's ability, and then we'll do post-training assessment. They started working on it, but that didn't happen because nobody wants to wash their linen in public. They somehow fear that if this comes out, maybe somewhere our hospital reputation will go down. So in Indian context, I think we are miles away from coming out with truth or to doing a study. And the very few hospitals, I'm not aware how many hospitals really are honestly practicing disclosure policy. Dr. Purnima, do you have any idea? Is there any hospital that's practicing? It's more, yeah, please.
Any specific, to be specific, I can't tell you, but I do know that the culture is slowly sweeping in, and definitely a lot of programs and streamlined way and SOPs are helping. Ma'am, I had raised my hand because I had one more point to add to the answer that we gave Pauravi. So if I may please submit.
Please go ahead, ma'am. Yeah.
See, as this is a evolving situation in healthcare, Madam will know that I have a very strong viewpoint on one thing, that education, healthcare education and changing attitudes, we are definitely doing it for the medical fraternity. But my viewpoint always is that it's not only enough educating the fraternity, it's time that the patient community at large also has formal or informal training on this. There is a difference between an error and a mistake. We all know that. So errors are inevitable part of any process, any procedure, and patients should also have this open-minded attitude. They should not react with violence or harm to the medical fraternity or take advantage of the situation. So for that also, I feel that community education at large and through various mediums, and this is what I had submitted to Madam, that it is very important that healthcare, though we practice it to the best of our ability, there is always a small chance of error, which is inherent error. So that patient should also be knowing, accepting, and I think at large community should be educated for this. So that's what I wanted to say, that we will be educating ourselves, we will formalize this education, we'll know how to deal with these situations, we will evolve, studies will take place. But at the same time, the community at large also should wake up to this fact that there is no intentional harm caused, but sometimes such situations can emerge, and how to go about it properly. And very important point is what is lawful and what is unlawful and unacceptable.
Absolutely. Thank you for adding that point, Dr. Purnima. Absolutely. So I think it's more to do with the individuals, how they handle the situation. If everybody agrees to handle it in a professional manner and coming out in an honest manner, then slowly probably that culture will evolve where people will come out. But then the management and administration have to support this disclosure. What if somebody discloses and he is punished for doing that? Then people will be discouraged to do it. Okay, so thank you so much, Dr. Vijay Agarwal, sir, for joining the session, friends. Can I request all of you to have your camera on? Thank you, sir, for joining us at such a late hour of the day. I thought we are closing, so we should have your blessings and your presence for all of us.
Thank you, Indu, and always a pleasure to be part of. Whenever you say that I have to be there, then I'm there.
Thank you. Thank you so much.
I was listening to Purnima ji's last comment about it. I can just tell her that we have also started a Patients for Patient Safety Foundation, which started as a Patients for Patient Safety initiative. But a lot of work is going on in exactly the direction that you're talking about. We're extremely aware of the fact that community also needs to be educated. So it's like a parallel streams that have to go on. I think important thing is that there are certain mistakes which cannot be condoned. So I always call them like never events. I mean, let's say operating on the right leg when the left leg was to be operated, on the right eye when the left was to be operated, and things of that kind at least should become a never event. So the problem is that in this era of super specialization, one of the biggest problem that is happening is because of what Induji is talking about is communication, coordination. And so the patient and the caregiver is lost sometimes as to, I would say, the absence of a family physician from the scene is the important thing. And today we have to understand that an MD medicine or an MD family medicine is required. We are not saying, I don't think a MBBS graduate is capable of becoming like a family physician with the kind of the knowledge explosion that has happened. So therefore, but to establish this role of a MD medicine as a great coordinator, because now if patient gets admitted in an ICU, the drop of a hat, the patient gets referred to a nephrologist, to a cardiologist, to a hepatologist, and the overall coordination takes a hit. And so many times we have seen that the patient is suffering in spite of 3-4 great people joining hands. So I always say that our fraternity, all the specialists have done tremendous job, tremendous work. We are doing fantastic advances that we have done over the last so many years. But just a small, I would say, small sensitization that we need to also see that our healthcare should become safer will take us a long way. Otherwise, you see, Hippocrates talked about first do no harm 2,500 years back. And this problem is not new. So it has been continuing. He must have thought about harm. That's why he created that oath that first do no harm. So the issue is this, that we all have to do something. And I think communication, and this communication that our Induji, who is, I would say, a real blessing to us and in the medical fraternity, that she is there to kind of guide, I think will go a long way. And communication is going to help not only, I would say, professionally, it helps you even in your own personal life and everywhere, I think is a great, great way to go. So we are extremely proud of being associated with her and her organization now. And Kaho will take all efforts to reach out to everybody, including the community, like what Purnima talked about. So thank you, Indu, for inviting me here.
Thank you so much. It's honor to have you here, sir. That's so wonderful. I'm glad, sir. So, sir, we have done with the topic and we are just going to talk about the feedback. So I will be requesting some of the participants to share their feedback. And if anybody is ready with their thoughts and if you are comfortable sharing, I'll be happy to hear your points. Thank you. So who would like to start? Okay, Parvi, go ahead. Yeah.
Ma'am, good evening, everyone. So this was a wonderful series of sessions that we have had till today. The most important thing that I feel all of us learned was how to communicate effectively, not just to inform the patient, but also empower professionals who are trying to communicate with the patient, and also safeguard the interests of both patient as well as the doctor and the hospital. This will not this information all that we learned in these sessions, this will not only empower us as professionals, but it will also help the patients in the long run in order to give quality healthcare. That's what I would like to share. And Indu ma'am, you facilitated the session extremely well, and all of us are really grateful that we got to learn so much from you. Thank you, ma'am.
Thank you so much, Dr. Parvi. Thank you for your feedback. Thank you. Yes, Dr. Purnima, please go ahead. Thank you.
First of all, a very warm good evening to Dr. Vijay Agarwal, sir. Namaste, sir. And good evening to all participants and to Dr. Indu, ma'am. Over the course of this course, we have developed warm rapport with each other. And there are so many youngsters in the group that they have brought a fresh perspective and promoted fresh thinking on the part of slight seniors like us. First of all, I would like to say that good communication always starts with good intention. And the intention of this program is so good and Dr. Indu ma'am, she has streamlined the course content so well into different sessions and given objective guidelines, which, if incorporated, will do a lot to make general delivery of healthcare better and also remove the anxiety, a certain degree of anxiety under which every healthcare professional labors. I am well aware of all the very good things in patient safety and patient engagement that CAHO is doing. So this is since I have been studying a lot with CAHO over the past 4-5 years. I'm very happy that we are going to promote this culture of patient safety, patient awareness, and bring communication as a tool to the healthcare professionals. The program is excellent, and the best part about it is Madam is so open to feedback, because feedback, once it is given and taken in the correct way, helps in improvement. And we will all be submitting our feedback, and maybe after a couple of years, we'll do the course again so that the newer and fresher content will benefit us greatly. Thank you, Kaho. Thank you, ma'am. And thank you, all my fellow participants.
Hopefully, some of you become another Indu Arneja.
Um,
Please understand that she was also a product of one of the Kaho sessions at one time in life. But today she is the leading light, and we want that many more people need to come, and we need many, many more to reach out to. Our country is so huge, so vast,
yes,
that it's really in need of the hour. And that's why I think this is a program for the trainers and not merely for people who will just listen and go away. So please spend your time and your energy in mastering the art to speak to others about it.
Yes, sir. Thank you, sir.
Thank you so much, sir. Thank you, Dr. Purnima. I think that was a wonderful feedback. And I take your words very seriously, very humbly. And I'll make sure that I make use of all the recommendations that you will give us in the feedback form, and we'll definitely integrate them. And I would really love, all of you to come forward and start doing training. And like Dr. Vijay Agrawal sir says that we need more and more people. And I completely agree with him. I mean, for me to reach everywhere, it's impossible. I mean, we really need people in every nook and corner of the hospital who can do these trainings, in their individual setup. So wonderful. Thank you so much. Anybody else who would like to share their?
I would like to
Please, sir. Go ahead.
share and, with Dr. Vijay Agarwal sir here and with you here and all our participants. So I would like to say that all these 10 sessions are really wonderful, ma'am. Especially the content that you have created, the series of these 10 things very carefully you have selected. And, communication obviously is so important. And the way you have taken the best part is it's been so interactive and so free for anybody to discuss, or, more of rather than a lecture series you have taken. And that makes a difference in that people will carry much home, especially all these role plays that you've done, group activities that you've done, the feedbacks that was mentioned, all these been extremely good. Some breaking bad news and addressing conflicts, all these things been very good sessions. So you are a wonderful program, effectively you take, ma'am. So it's really good. I'm sure all of the participants here have taken something home to make our healthcare safer, better, in which we can communicate with each other better, whether it is ourselves or whether it's patients, and overall improve the safety culture and reporting culture of reporting what's going wrong and rather than hiding. So thank you very much for all these sessions. Thank you.
Thank you so much, Dr. Matthews. I think hearing this from you is a huge compliment, because you all are very experienced and knowledgeable. And if you find this program, useful, I'm sure it's going to benefit, more and more people. And I hope that all of you take this learning and, share it with your fellow professionals, design short programs initially, but start implementing them. Because if you give gap and if you don't start implementing, you will forget. And all the information is available on YouTube. I have given you the link to the recordings. You can, visit the recordings n number of times, learn from it, and then try to customize your programs based on that. And of course, you can add many more points to it. And you have a lot of reading material also. But what I want all of you should start doing the program so that you don't forget what you have. Thank you so much once again. Thank you. Anybody else who would like to share their? Okay, Rose and then Dr. Manjusha. Go ahead, Rose.
Yes, ma'am. Good evening, everyone, and good evening, ma'am. Good evening, sir. So I really want to thank Indu, ma'am, for this uh, productive session, I should say. I really enjoyed the content, and like Dr. Matthew said, the role plays. Like even in doing it in physical, it is so difficult, but then you made it so easy online. And also we got a lot of insights from the seniors, and I'm so new to this healthcare industry, so I got to learn from each and every one of you, and also into this facilitations this on facilitation career as well. I'm so new, but then through this communication class, I'm so confident. Like it really helped me a lot how to communicate with the participants, and especially the name tag thing, I made it so mandatory now. It has become so much easy everywhere where I go, even to the airport and all. I'm so conscious of the name tags and all, and it's so easy to remember their names. Yeah, and apart from that, also I really enjoyed the session, and I'm also planning to start facilitating on healthcare communication. And whenever I need your help, ma'am, I'm sure you will always help me out again. And I really want to thank you, and I'm so grateful for that. Thank you so much.
Thank you so much, Rose. Thank you for your feedback. And I had that one of the points in my last points, that where I want to say that I'm open to mentoring, I'm open to working with you, because I know it's difficult to start. Once you start and you start doing it, then probably slowly you will be able to get the hang of it. But initially, everybody takes time, and I'm open to I'm just a message away or a call away. I always call back in case if I'm in a training program, and if you message me, I always promptly respond. And this will go on. That's why I'm not even dismantling the group, because we know we are all very mature people. Nobody is going to share any unnecessary forwards, but that way we will stay connected and we can share what we are doing or what we are learning. Thank you, Rose, for your feedback. Thank you. Yeah, Dr. Manjusha, please go ahead.
Good evening, sir. This program was one which I've been wanting to join for 2 or 3 years now. Actually, I connected with Madam a couple of years back, but then couldn't join. But then I'm happy I did it now. Uh, the first thing I would like to say about the program is this is one program which I was actually looking forward to every week. Though I've done many programs online, many courses online, it's usually, oh, it's that day again. But then this was one thing, probably because you are actually leaving the example of good communication, how you ought to be. And then, that's something that we look forward to becoming something of that stature after you finish your courses and as you go forward in your career. And then it was wonderful to connect with all the participants, seniors, juniors. Uh, all of them had different viewpoints. Actually, I was learning from each and every statement that came through the program. And uh, I was really glad that the PPTs were very crisp, very concise, and you don't have to actually read the whole thing. I was just going through my notes, and I hardly have 40 or 50 pages of the whole course, and I was thinking I missed something somewhere. But that's because it was very crisp and concise, and we were probably doing more of talking than having lecturing and lots of role plays. And I'm sure I'll take this back, and we surely need your mentoring, madam, because as sir said, listening to a program or just being a part of it and then becoming a trainer is an entirely different thing. All the hitches and glitches you find when you actually start curating your own program. And I'm sure all of us will need your help and the help of all our colleagues, senior colleagues in the group. Thank you so much for this program. And I'm sure if I have an opportunity, I would like to attend it, as Madam said, a couple of years from now.
Wonderful. Thank you, Dr. Manjusha. I think you have been one of the very sincere participants, always ready to contribute, share your learning, and learn from others. And I think the role plays that you did with all of us, they were very, very real life situations, and you acted very well. I think all of you who participated in role plays, I tried to engage everybody because everybody should get the feel of doing the role play. But then a lot of time you volunteer to do very difficult situations also. And that set a very good example for all of us, that I think that's how we need to handle situations. And in spite of your, seniority and your experience, all of you have acted very humble, very, very down to earth, participated very well. And that has motivated me to, make the program more and more useful and seriously preparing for it and bringing something new for everyone, so that you feel that, yes, there was some learning in every session. That has been my pursuit. Thank you for your feedback. Thank you, Dr. Manbush. So, Dr. Kausar, I think you raised your hand. I think you want to give your feedback.
Yeah. Yes, ma'am. Good evening, ma'am. Good evening, sir. Good evening to each and every participant. I would say at the end of 10 sessions, it's definitely a new beginning. Indu, ma'am, thank you so much for curating such a beautiful program for all of us. Your commitment definitely illustrates that hopefully we will be as good, or maybe half as good as facilitator as you have been.
Absolutely.
Yes, thank you so much, ma'am. We are also, I'm looking forward to being mentored by you so that I can also curate similar programs and hopefully, just like how Vijay sir said, make sure that patient safety is and prioritize it as much as I can through open communication and a feedback loop that enables us to really make the entire, the ecosystem of our practices more viable and more accepting for everybody. Thank you so much to each and every participant also for the insightful inputs, for the beautiful role plays. And definitely, I hope that all of us can keep in touch and with coming days also, add to the pool of experience that Indu ma'am has started for us. Hopefully, it'll be a very positive chain reaction. Thank you, and good evening to each and everyone.
Thank you, Dr. Kausar, for your feedback. And I really hope
this opportunity also to request that each one of you, if you are not a member of CAHO, please join CAHO. If you are not, please do it. Please understand one thing, that CAHO is not an organization. It is a movement.
The movement.
It is something, it is for everybody. And if we want to solve this problem, which started, as I told you, 2,500 years back, we all have to join. And I can only assure you that you are going to get much more out of this membership than any other kind of an association or something, because I said, we don't consider it like a organization or an association. It's a movement. And every day there are programs. Some of them are even free of cost. You will be very happy to know that we do a program, we do a webinar with ISQA. ISQA is the International Society for Quality Assurance, which does the accreditation of the accreditation bodies. They connect with CAHO to conduct a webinar on every first Tuesday of the month at 5 p.m. on one or the other topic relating to patient safety. And you're all, I mean, these are all free of cost kind of activities. And of course, even if you are not a member, a lot of information is available through our website. Please, you are most welcome. But we will very much want that you join, because we feel that the movement will become stronger. You will also, I mean, we want this program of Induji to be almost happening every month. If not this thing, we want at least every month 20-25 people should be joining into a similar kind of a thing. And let's say out of those 200 people, even if we want 20 people to become trainers and to take it forward, I think we would have fulfilled some part of our dream of roping her into CAHO. Otherwise, she has a very flourishing, her own kind of a body and institution. She was very gracious to join CAHO and the partnering. But we want you to now promote this. And I would say that while we say all good things, of course, about the course, whatever you feel can make the course even better, don't hesitate in giving that feedback also. And same thing about, I will say about KAHO, about any activity of KAHO. If you are a member, and as far as KAHO is concerned, I always feel that it is nothing, all of you are KAHO, and just join. That's all.
Thank you, sir. Thank you for your kind words. Yeah. So it's 10 o'clock, and so we are very particular about time. We try to close on time. And thank you, everyone. I think you all gave a wonderful feedback. I wish, I mean, and I was thinking, sir, that from next time onwards, we will not close on session 10. We will keep 1 hour session, on the next week, not on the same day, but in the next week, so that we can do a formal closing and we can also take feedback and also discuss about how can we take it forward. But couple of things that I want to tell all of you is that let's stay connected. Let's think of how you would like to take it forward, make a plan, whatever help you require from me in terms of guidelines in what topic to cover for a particular clientele or what are the issues, how that can be addressed. And then if you prepare your presentation, if you share with me and if you want me to give some input, I can do that for all of you. But don't stop it here. Continue doing, because initially there will be some bottlenecks, there will be some issues. Like when I did my program with KAHO, that was 2014, sir, when I did with KAHO. Even I was like initially very new to the whole thing, but then I kept working on it. And then luckily I got the chance to do almost like 500 training programs, daily for Delhi government. And that's how I refined my content. So initially, wherever you are working, whichever place you are working, if you start doing programs for your support staff, for your front desk staff, for your back end staff, slowly you will get a hang of it, and then you can improve your presentation and role plays and activities, and automatically you will start getting ideas also. Plus, you have a repository of my videos which you can visit anytime, and you can learn from that and implement in your workplace. I've put everything on open platform so that they don't have any restriction to visit my videos. They can go and visit and see all the presentations and create their own presentation. That's the idea.
We made a WhatsApp group of these people, and even earlier ones, all the trainers, persons, this thing should be a part. Please
community kind of a thing.
Allow me to join also, and I'll be very happy to interact with all of them.
Sure, sir. Sure, I will do that. I was thinking of creating a community. So there are around 300 trainers, who have done this program. Yes, so I'll create a community, and then definitely, sir, I will add you. It will be pleasure and honor to have you, on that platform. So, sir, thank you so much. So I think we have covered most of the points. Two things for for claiming your certificate, sir. The two criterion that I have set is that anybody who has attended 8 and more than 8 sessions and they have completed their assignment, you can claim your certificate. So I have circulated that form with you. I'm going to recirculate that Google form where you have, not Google form, it's a Word form where you have to write how many sessions you have attended and if you have submitted your assignment. So assignment to them was that they have to create a video of their presentation of 5 minutes talking about different pedagogies. So everybody has taken one or the other topic like storytelling, PPT, role play, critical thinking, and everybody has created 5 minutes video. They have made the presentation and they have recorded the video and they have shared in the group. So these are the two criteria. Make sure, I'm sure you must be knowing how many sessions you have attended, and from the video also we can check who all have attended the program. And if you have completed your this thing, you will get a certificate jointly signed by KAHO and INC. Everything is ready. I just need the details, and you will get the certificate if you have attended 8 and more sessions. And if you have not attended, you will have to attend those sessions in the forthcoming programs. Dr. Nirankar is one who attended the program. He joined the program, sir. He's from Reliance Hospital, Jamnagar. So he started the program, but he could not attend for his professional reasons. At this batch, he is completing his, but he has attended all the sessions very regularly. And I hope you were benefited and it was worth investing the time that you have given to the program.
Yeah, ma'am, I'm very grateful that this time I got an opportunity to join, because since last 2 years I'm trying, but there is, due to some works or some work related issues, I'm not able to join. But this time I have successfully completed, and the sessions and everything is very good. I really appreciate it.
Thank you so much. Thank you. So thank you so much, everyone. I wish you all the best, and let's stay connected.
Thank you, ma'am.
Thank you. Thank you so much. And do
Thank
share
you,
all
ma'am.
the work you do in the group and with me. I can post it on LinkedIn as your work. As your work.
Thank you
Sure,
so
ma'am.
much.
Thank you so much. Thank you,
Thank you so
ma'am.
much, ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Good night,
Thank
ma'am.
you.
Thank you, ma'am.
Good
Thank you so
night.
much.
Good night.
Thank you, ma'am. Good night, ma'am.
Good night. Good night. Thank you so much.
Thank you, ma'am. Good night, ma'am. Thank you, sir.
Right. Thank you
Night.
so much. Good night.